women who are serving overseas, who are killing, who are being killed, who are being maimed, who are coming home with these psychological wounds that as we spoke in part one, 22 veterans a day are killing themselves.
Post-traumatic stress disorder is defined in the DSM-5 as based on 8 criteria. The first DSM criterion has 4 components, involving directly experiencing the traumatic event, witnessing the event as it occurs to others, learning that the traumatic event occurred to a close family member or friend, or repeated or extreme exposure to aversive details of the event. The second criterion involves the persistent re-experiencing of the event through thoughts, dreams, hallucinations, or dissociative flashback episodes, among others. The third criterion involves avoidance of stimuli that are associated with the trauma and numbing of general responsiveness in terms of thoughts and feelings associated with the event, or avoidance of people, places, or activities that may trigger recollections of the event. The fourth criterion is negative alterations in cognitions and mood associated with the traumatic event, such as the inability to remember an important aspect of the event, persistent negative thoughts or emotions about the event, and/or feelings of detachment. The fifth criterion is marked alterations in arousal and reactivity as evidenced by 2 or more of the following listed. The remaining 3 criteria are as follows. The duration of symptoms must be more than 1 month, the disturbance must cause clinically significant distress or impairment in functioning, and the disturbance must not be attributable to the physiological effects of a substance or other medical condition. As shown in the beginning of this video, there are many different possible causes of PTSD. Trauma, combat, terrorist attacks, natural disasters, assault, and sudden death of a loved one. Although many people experience traumatic events, most do not develop PTSD. Individuals who experience the same or a similar stressor may or may not develop the disorder. The identification of the factors that might account for these differences can assist in our understanding of the etiology of PTSD and in the development of preventative approaches for people who are at highest risk for developing the disorder. Potential PTSD risk factors can be divided into 3 major categories: pre-existing factors specific to the individual, factors related to the traumatic event, including one's immediate response during the trauma, and events that occur following the trauma. There are certain pre-existing factors that have been related to trauma exposure and the development of PTSD that are specific to the individual. First and foremost is genetics. It appears that vulnerability to PTSD can be passed on through generations. Another factor is familial psychopathology. Early fear conditioning research in animals suggests that there may be a genetic component associated with variability and sensitivity to environmental stress, according to a study done by Anisman in 1979. Although studies of such a mechanism in humans do not exist, several twin and family studies have examined the heritability of PTSD. Additionally, a family history of anxiety, PTSD, and trauma may predispose family members to the disorder. There are also demographic factors like gender and age. Studies have shown that women appear to be more at risk for developing PTSD than men. According to a recent study, men report having experienced more traumatic events in their lives, but women have a higher prevalence of PTSD. Not only are women twice as likely to develop PTSD, but the disorder's course in women tends to be more chronic. Another factor is age. Age at the time of the traumatic event is frequently seen as an important determinant of response, with the very young and the very old carrying additional risk for disorder upon exposure. Schiraldi also mentions that other factors such as life stressors, poor coping skills, and pessimistic or introvert-related personality traits are also correlated with the increased risk of developing PTSD. Additionally, increasing evidence suggests that prior life trauma and cumulative adversity may increase the risk of PTSD following a later trauma. Psychopathology prior to the trauma is another pre-existing factor. Several studies identified the prior existence of a psychiatric condition as a risk factor for the development of PTSD. In meta-analyses conducted by researchers in 2000 and 2003, psychiatric history was found to confer a small degree of risk for the development of PTSD. The presence of psychopathology, such as an addictive disorder or conduct disorder, may also lead to exposure to traumatic events themselves. Researchers have also examined post-trauma factors and their contribution to the development and maintenance of PTSD. However, among such factors, social support has received the most attention. Across 11 studies, it was found that perceived social support following the traumatic event was associated with PTSD symptoms. Lack of social support can contribute to the heightening of symptoms and vice versa. For example, in a study observing Vietnam veterans, it was found that emotional sustenance and instrumental assistance, in addition to social support, decreased the odds of ever having PTSD. The prevalence rate of the disorder is 7.8%, and the median age is 23. Patients with PTSD are assessed based on the 8 criteria in the DSM-5. They can either be assessed by means of structured interviews, questionnaires, or clinician diagnosis. The Minnesota Multiphasic Personality Inventory is commonly used for the psychological assessment of a potential patient with PTSD. Two other common ways of identifying PTSD is through the PSSI scale and the CAP scale. As evidenced in a study by researchers Foa and Tallon, both are comparable measures of assessment because it appears that the PSSI scale may have a slightly higher sensitivity, whereas the CAP scale may have a slightly higher specificity. Overall, having a generalized biological vulnerability such as gender or age, in addition to a generalized psychological vulnerability such as comorbid disorders, or increased anxiety coupled with a traumatic experience, as represented in the top portion of this diagram, can lead to a greater chance of the development of PTSD. Therefore, there is no single cause of PTSD. It is the result of a combination of biological and psychological factors in addition to prior vulnerabilities that ultimately lead to this disorder. Most theoretical models suggest the presence of a dose-response model in which symptom severity is a function of traumatic event severity. Peritraumatic variables include a range of factors such as physiology, affect, and cognition that occur during the trauma, as well as particular aspects of the type of traumatic event. In the neurobiological model, threatening cues activate the corticotropin-releasing factor, which triggers fear and anxiety areas of the brain, such as the amygdala. It also increases the hypothalamic pituitary adrenal axis and releases cortisol in the body. Amygdala responsivity is positively associated with symptom severity in PTSD, whereas medial prefrontal cortex responsivity is inversely associated with symptom severity. In 2004, researchers conducted several retrospective and cross-sectional studies which found relationships between cognitive beliefs and PTSD severity. Such cognitions included negative appraisals of trauma symptoms, low self-efficacy, and external locus of control. According to the American Journal of Psychiatry, PTSD is often a persistent and chronic disorder. However, a study by McFarland shows that PTSD has a significant rate of natural remission in a number of cases. This emphasizes the importance of understanding the factors that might influence the timing of remission and those that might exacerbate the symptoms or modify them in the course of the disorder. Kessler suggests that if PTSD is not resolved within 72 months, it has a very substantial probability of remaining chronic. There are many factors that go into determining the prognosis of PTSD. However, the outcome is more promising if certain conditions are met, such as less severe trauma, early intervention, strong social support, no family history of PTSD, and if the patient is male. In 1979, a researcher proposed a typical course that PTSD runs from traumatic stress reaction to recovery, which encompasses 4 stages from the initial stage of the outcry to the 4th stage of work to completion. PTSD commonly co-occurs with other psychiatric disorders. About 80% of individuals with chronic PTSD meet criteria for one or more comorbid conditions such as depression. Cognitive behavioral therapy, medications, exposure therapy, and eye movement desensitization and reprocessing are some of the most common forms of treatment for PTSD. The strongest empirical evidence for the treatment of chronic PTSD comes from cognitive behavioral therapies, such as cognitive therapy and prolonged exposure. According to a study by Harvey Bryant and Terrier, CBT is proven to be the most safe and effective treatment for PTSD. There have been significant advancements in the pharmacologic management of PTSD in the past 2 decades. Multiple randomized clinical trials have noted the efficacy of selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors. They are a type of antidepressant that increase the levels of serotonin in the brain. SSRIs include Celexa, Prozac, Paxil, and Zoloft. Although they are helpful for some, they are highly addictive, and studies have shown that they are not as effective as CBT. Future treatment of PTSD is looking towards the use of virtual reality. Studies testing this have only been released in the past year. Trauma doesn't end when the guns stop firing, when the storm passes, or when the rapist is convicted. That is when it begins, and PTSD is a mental disorder that affects almost every aspect of an individual's life.